Hi, and welcome to the Anti-Waffle podcast of Em and Pixie.
Woohoo!
And together we'll try to talk about research about any gobbledygook. Each episode we'll be talking to a researcher who will discuss the work they're doing, looking at why this research is important and asking how did they get into this field. We hope that it will be informative and interesting and bring a bit of the academic world into the real world. Today we have Professor Bryony Dean Franklin, Professor of Medication Safety at UCL's School of Pharmacy. Hi Bryony, thanks for being here today. It's lovely to talk to you. Would you like to start by telling us about your research?
Yeah, of course. So my research is all around medication safety. And to give a bit of context to this, we as researchers put a lot of work into developing new drugs and making them into medicines so that they can be used to prevent and treat disease. But my research focuses on what happens next, what happens when medicines get into the hands of real people. We know that errors can sometimes occur in how medicines are prescribed, dispensed and administered, and that things can sometimes go wrong, like in terms of communication between doctors, pharmacists, nurses, and patients and carers. So what I'm interested in is what might go wrong sometimes, why, and then most importantly, how we can prevent things from going wrong in the future to make medicines use as safe as possible.
Wow. So how do you get the data, the information? Who do you speak to, and how do you determine, oh, actually this is how do you catch the errors? I guess that's what I'm asking. So like do you find out from the patients or from the doctors, or did you wait around A&E for this was a problem with the medication they took? How do you find the data?
Well, yeah, great question. It could be any of those, actually. So sometimes we do observations of staff on hospital wards, so maybe nurses, doctors, pharmacists. Sometimes we talk to patients or ask them to record things. Sometimes we might audit different documents to see where information has got a bit lost in translation, perhaps when it's being transferred from hospital to the GP surgery, for example. Or we might look in sort of big data sets for evidence that things have gone a bit wrong. So it really depends on the research question. There's a lot of different ways we can use, and we'll use the best way to answer the specific research question.
Interesting. No, that's really cool. And but do you find you get like resistance from either the hospital staff or GPs or from the patients? Like people don't like admitting when they've got something wrong or when there's been an error.
Yeah, absolutely. So it's really important that the research is handled really sensitively and being aware of that. Actually, I don't find much resistance because, I think all healthcare professionals and all patients and carers want to work towards a system that works better and is safer for everybody. So, as long as we're framing the work in a positive way, which of course it is, it's about trying to make things better for everybody, then you don't tend to get any resistance. It's important to be aware of sort of confidentiality and being clear that this isn't about finger pointing, it's about working together to find solutions.
Thank you.
Can you talk us through the sort of the process of the steps? Does it begin with if you were starting with a new drug, would you have a process of following it through and finding out about how people take it?
Yeah, so my research tends to span all different kinds of drugs. It's more about focusing on the processes. So sometimes we do studies perhaps looking at how a specific group of drugs, like maybe antibiotics, gets used. But usually we're looking at all medicines rather than focusing on one. So for example, we might be looking at what happens when hospital staff take a drug history from a patient when they're admitted to hospital. So this would involve being able to establish exactly what the patient was taking before they came into hospital, so that we can then make sure that drugs carry on being prescribed when they're in the hospital, and also so we can find out if there might be a reason why one of those medicines perhaps caused their admission. So it's really important that hospital staff can take a good, what we call a drug history. So that relates to all drugs. So for example, we might be looking at how good staff are at taking those drug histories and whether there's patients things that patients can do that will help, such as carrying a list of their medicines on their phone or on a piece of paper, or bringing their medicines in with them when they come into hospital. So it's really about starting with, well, what's the problem? What might be some of the things that contribute to that problem? And then what might some of the solutions be, and testing them out in practice.
Wow. So with taking the history then, say, as the example you gave, isn't that on the system, surely, or is that still an old NHS problem where one department doesn't have access to the information of another department? Surely that should be something they can access?
Well, it's a bit of both of those actually, Pixie. So these days there are much better joined up systems. So hospital staff can now, with the patient's permission, access, for example, their GP prescribing records. But not all medicines will be recorded there. So things that somebody buys over the counter, for example, won't be on the GP list because they're buying it separately. And sometimes, particularly these days, there's some quite important medicines that are available over the counter, and if you pay for your prescriptions, it might be cheaper to buy them yourself than pay a prescription charge. So it's really important that we know about those. Also, sometimes medicines from specialist clinics, perhaps if somebody goes to a specialist renal clinic or a specialist HIV clinic, those won't necessarily be documented on their GP's records either. And then an extra complication is that the GP records may or may not be up to date. So sometimes medicines are on there that the patient isn't taking anymore. So it's really important that we don't just use that list and take it at face value, that we also have another sort of separate conversation with the patient or their carer.
Right. Wow. No, that's really interesting and important. Yeah, I forget about over-the-counter stuff because so most of medication that I have to take is over the counter. It's usually some kind of form of painkiller or something like that. But yeah, no, that's very important.
So sometimes people might be buying, for example, aspirin that they take every day, or antihistamines for allergies. There's actually quite a lot of medicines that you can buy over the counter that's important that we know about if a patient has healthcare.
Yeah. So like with sometimes I have a problem with my knee or joints, and so I will take the codeine and paracetamol ones, the really strong painkillers. And so but yes, whenever they're selling me those, they're always saying, are you on anything else, and what are you doing? And so like my mum can't take them, and it's like because she's on high blood pressure meds. So it's a very wide area, wide field to try and monitor and keep safe, isn't it?
Yeah, well, that's right. So, and that's exactly what my research is looking at. So looking to see what can we support patients and carers in doing, how can we support healthcare professionals in practicing safely, and how can we, develop good systems. So that might involve using technology. So electronic prescribing systems are very common now. How can we make better use of those to make drug use safer? In hospitals, we've developing new systems around using barcodes to check the medicine and the patients are the right ones for each other. And often hospitals now will have robotic dispensing systems in the pharmacy and sometimes automated cabinets on the wards. So it's also about looking at the systems we use and how can we, get the most value out of those in terms of supporting patient safety.
Wow.
As Pixie says, that there's so many different variables that are different areas. That's impressive to try and gather all that information. And my question is, do you work closely with the drug companies as well?
I work mainly with hospitals, staff, such as pharmacists, doctors, nurses, and actually a lot of my work is with patients and carers and members of the public as well. We have done some bits of work with pharmaceutical companies, but because my research is more about what happens when the pharmaceutical company have sort of finished their work, it tends to be, more working with the frontline users of the medicines. So as I say, what I'm interested in is, let's assume the pharmaceutical company have done a great job in developing a drug, they've formulated it into a medicine, they've done clinical trials that show it works, and then what I'm interested in is how do we use it in the best way possible after that.
Wow. So, like when you're dealing with patients and the users, has there ever been sort of like a where they've given a suggestion of a different way of either administering or monitoring or communicating about what should be taken or anything like that that you've been able to sort of like use and implement?
Yeah, absolutely. And we love that when patients and members of the public have got such important insights, and it's great to be able to capture those. So yes, absolutely. So we did one piece of work with interviewing and observing practice on inpatient wards. And a lot of the patients said, well, when I'm at home, I take my own medicines. I can make sure I'm taking them at the right time. How come when I'm in hospital, it's the nurses that do it all the time? And actually, I am well enough to take my medicines at the moment. Why can't I do that? So that then led into a quality improvement study in a group of hospitals in West London to facilitate a system where patients who were deemed competent could then administer some of their own medicines while they were in hospital. It meant they were staying involved. They could take them at the time they would normally take at home, rather than sort of taking away their autonomy. And there's been other examples where we've been able to sort of develop ideas with members of the public as well.
Right. Of course, I never even thought of that. Yeah, you are just handed it, aren't you? And when you're in the hospital, whereas because at first I was thinking, oh, but then they'll have access to they'll have to have the bottle there, and they'll have access to, but they'd have the bottle at home. So it's like, yes, no, that makes perfect sense. It's a really good suggestion.
Yeah, but you're right. There's things to think about safe storage. So what we would generally do in the hospital is that the patient would have a little lockable cabinet by their bedside with a key that either they might hold, or the nurse maybe has to come and unlock the cabinet for them. But the patient can then take their medicines out, because, as you say, we can't have sort of bottles of medicines hanging around that somebody's visitor might pick up. People might have children coming in to visit the patient in the bed next door or something. So we absolutely don't want medicines sort of out and accessible, but we can develop ways in which patients can access them, and but still having them locked away. But it just means that for people who like having that autonomy, maybe they've got medicines that work best given at very specific times. It helps to get the patient involved, and also can help them be familiar with the medicines they're taking before they go home again.
Yeah, no, it's a very good point.
Yeah, it's quite it's almost empowering, isn't it, to be able to sort of do your own medication like you would at home. Actually makes you feel more in control of yourself and of what's happening to you, doesn't it? Which is quite important when you're in hospital.
Yeah, absolutely. And that's one of the things we heard from our patients, was that it felt very strange having that autonomy taken away from them. Now, of course, for many patients, they're actually too unwell when they're in hospital, and it would feel like an additional sort of stress and pressure to have to do that. Or maybe they don't administer their own medicines at home. Maybe a family carer helps them with it. So it's not appropriate for everybody. So it's about identifying what works for different people. And and I guess respecting people's individual choices as well.
It goes some way to them feeling getting better quicker and getting out of there as well, if they're still engaging with their own care and with life.
Absolutely, absolutely, yes, because we don't want to take that away from people if they've got to be in hospital for some reason.
Throughout your research, has there ever been a time when something's really surprised you, something you found out?
Oh, probably lots of examples. I could give you one example, actually. We were doing some work about how we could provide feedback to hospital doctors about their prescribing, so that they could further develop sort of safe prescribing habits and learn from each other. And one of the things that we knew is that pharmacists often pick up sort of prescribing errors, usually relatively minor errors, and they will contact the doctor to get them corrected before they can reach the patient. It's a good system. It's partly what pharmacists do in hospitals. They check all the prescriptions, and if this is like a second check, if something doesn't look quite right, they'll contact the doctor. So we knew that lots of these errors were being picked up by the pharmacists. But interestingly, when we talked to doctors, they would say things like, oh no, I've never made an error. Or they'd say things like, I'm often asked to change my drug charts, but I don't think I've ever been told I've been making an error. So what we found out when we dug a bit deeper, we concluded that the pharmacists were sort of being a bit British about it all and were asking the doctor very, very politely to change something on the drug chart, but they were never referring to it as an error or a mistake, perhaps not wanting to be confrontational. But that meant they were never having a conversation with the doctor about how it had happened or how it could be prevented. And the doctors were never sort of filing it in their brain as, oh, I'd made an error there. I wonder if there's something I need to do differently. So that for me was a bit of a surprise and really interesting about the sort of dynamics between the two professional groups. So what we did then was worked with the doctors and the pharmacists to explore how best to have these conversations so that they were non-threatening, but also so that it was clear what could be, what had happened and what needed to be done differently going forwards. So that involved sort of, actually calling it an error, but rather than saying you've made an error, it would be about saying, oh, there's an error on this medicine or there's an error on this chart. And that's how the doctors wanted to be told. So we worked up some sort of almost scripts that the pharmacists could use initially in having those conversations. And then from that work, we also developed a prescribing tip of the fortnight, which we still send out in the hospital trust that I also work in, highlighting a common or potentially serious error and how all prescribers can learn from it, with some tips to prevent it happening again.
Well, that's really interesting, isn't it? Because, of course, from the doctor's point of view, they probably just thought they were being helpful and, and say, oh, can we change this? Or they could, rather than, well, I'm not going to let my ego get in the way and and I will yes, I'll change it for you. There you go. And it's like, but no, it was actually an error. Yeah, that's fascinating.
Yeah, we were really interested in about that. Yeah, absolutely. And I guess that balance of not wanting to have a difficult conversation, which I can completely understand, but at the same time, sometimes you do have to call out what it is in order for people to learn from it.
Yeah, no, absolutely. Yeah, because I'm always quite keen. That was the way I brought up my daughter, and it was like, I might have been over picky, but I knew that if she didn't know something was wrong, then she'd do it exactly the same way again. And so it's same thing.
Yeah, it's about, I guess, being appropriately sort of clear and assertive on both sides, isn't it, while still being respectful and sensitive, and just getting that balance right, really.
Yeah. Wow. Mm-hmm.
So another project that I'm working on at the moment involves the use of barcoding to check the identity of both the patient and the wristband. So barcode medication administration systems are being introduced in quite a lot of hospitals in the UK and around the world. And how these work is that when giving a medicine to the patient, the nurse will scan a barcode on their wristband and then scan the barcodes on each of the medicine boxes. And the idea is that the system just verifies that it's the medicine that's been prescribed for that patient. So there's potential sort of safety benefits of using this system. But what we found was that the system wasn't being used very often, that there seemed to be quite a lot of barriers to its use. Perhaps the nursing staff felt that it could take a bit longer, or they were worried that patients might feel like not be that comfortable about being barcode zapped, that maybe they'd feel a bit like they were, a product in the supermarket or something.
Yeah.
So we've been doing some work with our colleagues at a hospital in London to sort of explore some of these issues, with doing interviews with nurses and with patients as well, to see what the patients do actually think. And interestingly, the patients don't seem to mind at all. They see it as being a safety thing, if indeed they've noticed it at all. But then also exploring from the nurse's point of view, what might be the things that would help them use the system and use it well, and what might be the things that are being a barrier. So some of them are really practical things, like the way the trolley is designed, or whether the Bluetooth is working between the scanner and the drug trolley computer, whether enough drugs have a barcode that it feels like you can use this for all of the drugs, and things like that. So we'll then be using that to try and make it much easier for the nurses to make this the system that, that they want to use and that they will always use.
Mm-hmm. So could that be tied in with everything and not just the medicine? Could it be tied in with because back to my knee, I had an operation in October, and it was like about 6 times that I was asked, oh, what's your name, what are you in for, and what are your, which knee, and just to make sure, to check and double check again. And I kept thinking, how many times has this gone wrong? That they're having to double check it every step of the way. They were sort of like double checking everything. So so if they've got this barcode or QR code, I suppose it would be by now, would that cover for everything? So it would it link in with other departments and with other not just the medication, but their medical history and everything else like that?
Oh, Pixie, that's so funny. It's so often that we hear that from patients. If I check somebody's name and date of birth or something, there's that sense of, I've been asked this so many times.
Yeah.
So number one, I think everybody relates to that. And I guess a lot of it is just each healthcare provider wants to make sure they're talking to the right person, because patients do occasionally move beds, either intentionally or unintentionally. And, you just always want to make sure you're speaking to the right person. And I think it's every surgeon's absolute nightmare to operate on the wrong knee or the wrong side, so you always check. But that aside, these systems have wider applicability. So similar systems are often used now for blood products when administering bloods to patients in hospitals. And they can, that in particular checking the patient's identity could be used for other things. The system a lot of hospitals have got at the moment, it's very much sort of linked to the drug trolleys. So it is a bit specific to drugs because just the way the hardware is set up. But absolutely, you're right. This technology can be used in so many different ways.
Yes. That's been good. Could you tell us, how did you get into this area of research?
Yeah, sure. So I am a pharmacist by background myself. So the safe use of medicines is important to me, sort of professionally, as well as being a particular personal interest. So I was working as a hospital pharmacist in the intensive care unit in my 20s, and I saw how things could sometimes go wrong, even amongst quite, very committed and extremely capable staff. So I guess the nature of being human is that, occasionally we do miss things or make assumptions about what's going on, or we think we've communicated clearly and we haven't. But then I had the opportunity in sort of the mid-1990s, I think it was, so showing my age now, to do some research comparing the way we did things in the UK with the way they were done in the USA. And so it was really, somebody was looking for somebody to do this project as part of a master's project. And to be honest, I just fancied a trip to the USA. So I went and spent a summer in the USA doing a study of how medicines are administered to hospital inpatients in America, which is they use quite a different system to we do, with individual doses of tablets sort of packaged individually, and they didn't use the same system for documenting medicines and prescribing medicines as we do. So one of the things I learned from that is that the system we use is really important. And it was interesting so I did some work observing medicines being administered both in the American hospital and in a hospital in London. And what I saw was that actually there were similar rates of errors, relatively low, thankfully, but errors did occur in both systems, but they were very different sorts of errors. So what I learned was that the way the system is set up and used really matters, and that our systems affect the types and the nature of the errors that we get. So I was really interested in that, and I suppose I came back thinking, actually, this is a really interesting research area and I'd like to do more. So I was then lucky to get some funding to do a PhD. So I did a PhD then a few years later, actually looking at this in a lot more detail and trialing out different methods of medicine storage and supply and looking to see which was safer. And then after that, I did some postdoctoral research looking at prescribing errors and the sorts of errors that are made in prescribing. So really, since then, it's been just sort of very much my research area that I've kept with and explored further.
America, the gift that keeps on giving.
It was such an interesting experience, but really also really opened my eyes to the fact that countries and maybe even individual hospitals don't all do things the same way, and that there's a lot we can learn from each other as to what good might look like, and just really sort of learning from what we can.
And it's fascinating as well with America that that just because you're paying up front, rather than with like how it is with the NHS, doesn't necessarily mean that it's better or that it's more higher quality. It's just, you just got to find the money straight away.
Yeah.
It's very interesting.
Yeah, no, absolutely. And I think, my main learning was it's not necessarily better or worse, it's different, different ways of doing it. But interestingly, partly the reason why they did have a slightly different system was because they needed to be able to charge each patient for each tablet, which of course we don't have to worry about mostly in the NHS.
Interesting.
And could you sum up why your research is so important?
Well, I think anything that makes healthcare safer for patients and the public has got to be really important. So I think, and of course, medicine is the most widely and commonly used healthcare intervention across our healthcare. Whether you're in hospital or whether you go and see a GP, medication is probably the most likely intervention that you'll be given. So if we can make medicines used safer, it's got the potential to make things better for huge numbers of people. So I guess my ultimate goal is to support patients, carers and healthcare professionals in the safe use of medicines, whether that's in hospitals, care homes, patients' own homes or anywhere else.
Great.
Yeah, that's brilliant. Thank you ever so much. Thank you. Thank you for your time. Thank you so much for speaking to us today. It's been lovely to hear about your research, and thank you to everybody for listening. We'll put up all the links on our Twitter account, which is at Anti-Waffle Pod. Please do get in touch. We'd love to hear from you. Bye.
Bye.